Hi there, this is Aaron Filler. I'm a neurosurgeon in Santa Monica, California, and this talk concerns the surgical anatomy relevant to treatment of nerve injuries of the lower extremity. I want to certainly acknowledge that the bulk of the illustrations and the techniques that I'm referring to here and that are set forth in the chapter are attributable to Robert Thiel, whose early passing is deeply regretted by all of us. And the substance in this chapter update should certainly be considered a tribute to his contributions as well. So I also want to mention that some of the particular decompressions, such as for the tibial nerve and the tarsal tunnel, are covered in other chapters, and that would be chapter 276, and decompressions in the pelvis, such as for piriformis syndrome, pudendal neuralgia, and obturator internus syndromes, are covered in chapter 278. So the subject matter for this chapter includes lumbosacral plexus, the obturator nerve, femoral nerve, lateral femoral cutaneous nerve, sciatic nerve, peroneal nerve, and tibial nerve, and the exposures that are covered tend to be extensile or large exposures, and these have been particularly advocated for major nerve injuries in order to provide sufficient access for two-point intraoperative nerve stimulation, where a stimulating and receiving electrode could both be placed on either side of a traumatic neuroma in order to determine whether or not a portion of nerve could be resected. And these approaches are generally as opposed to approaches set forth in the nerve decompression chapters, which tend towards smaller incisions, very targeted, to minimize the amount of exposure to reach a point of entrapment with an advance intention to do a nerve release, wherein the specific target is identified in advance by techniques such as magnetic resonance neurography. So starting at the top, although many neurosurgeons are familiar with the potential for a pseudomeningocele to form in the neck in the situation of severe tension trauma on the brachial plexus. It is rare, but this can happen as to traction and for the lower extremity and pelvis as well. And similarly, when this is suspected, a pseudomeningocele will be a clear sign of a potential avulsion injury. Now, just stepping through the lumbosacral plexus, it doesn't quite have the degree of mixing and transferring from higher spinal levels to lower spinal levels, which is seen in the brachial plexus, but this can be usefully thought of in terms of these four major elements, and then a fifth that crosses over. So the fifth, not marked here, is the ilioinguinal and genitofemoral nerves, which generally follow the body wall, come across above the anterior sacroiliac spine, above the inguinal ligament, whereas the lateral femoral cutaneous nerve, which runs between the tensor fascia lata muscle and the vastus, passes under the inguinal ligament, but is purely sensory. The femoral nerve conducting motor and sensory, motor for mostly anterior thigh, knee extensors, and sensory extending in the sural nerve all the way down into the lower leg. The obturator nerve, responsible for the major adductors, and the sciatic nerve. And then to keep in mind that you can identify your locations in a low inguinal approach by identifying the femoral artery by palpation, knowing that the femoral nerve will be lateral under the nerve artery vein sequence, whereas the obturator nerve will be medial to the palpable femoral artery. And this would just help guide you on an initial approach. It also can assure that you are at a good distance from the femoral nerve when dealing with possible resections for problems with sensory nerves, such as for the lateral femorocutaneous nerve or for the ilioinguinal nerve. In dealing with injuries of the pelvis with neurologic consequences, you have to consider the intrapelvic course of the nerve elements, so that, for instance, here with a displaced acetabular fracture, you would expect to see impacts on both the femoral nerve and the obturator nerve because of displacement along their intrapelvic course. Now, in contrast to the classical major explorations, my own input really is to advise a detailed MR neurography study when a complex or puzzling array of symptoms needs to be resolved. So here we have a gunshot wound into the pelvis with partial losses in a number of nerve elements. And what you see in the top A panel is the L4 spinal nerve expanding into a terminal neuroma, the S1 spinal nerve traversing below the level of abnormality, and then we see in panel B the femoral nerve with a distal neuroma, sometimes called a traumatic glioma or a glial mass. And then what you see in C and D is a projection neurogram that assembles the elements. And then to further clarify it, what's been done is to use a reconstruction algorithm where the operator draws or places a line along the expected course of the L4 spinal nerve, the area of the gunshot wound neuroma, and then traversing distally in the femoral nerve, and then the software generates an image of the nerve along that course, and therefore we see how the L4 spinal nerve in D there progresses into a neuroma in continuity with the femoral nerve emerging. So you have a very good idea of what you're going to encounter surgically and exactly where you need to go and where you need to test before commencing the surgery. And here we see a large retroperitoneal hematoma, and this is just helpful when you think about this in light of the different lumbosacral plexus components, because at the upper end, this will be in continuity with L3 and L4 spinal nerves, but it reaches into the plane through which the L5 spinal nerve heads out to join the head of the sciatic nerve just inside the sciatic notch, and at the same time reaches onto the sacral surface and can extend down to the impar ganglion, causing pelvic and genital saddle area sensory and functional abnormalities. So in trying to deal with the complex neurologic picture after a major trauma or intra-abdominal or flank hemorrhage, it's important to carefully consider the various components of the plexus and other planes along which nerves travel as they progress from the spinal area to the periphery in the pelvis and low spine. So discussing access to treatment for the distal femoral nerve, just below the inguinal ligament, certainly you'd be guided initially by marking the position of the femoral artery, which will take you right to the nerve course. Remembering again, VAN, vein, artery, nerve, where the nerve is lateral, and you can always check that in the textbook. And being able to understand the relationship to the inguinal ligament. Now, nonetheless, it's always very helpful to have some EMG electrodes in, no paralysis, and a peripheral nerve stimulator in your hand to readily distinguish the components, keeping in mind that the branches to the pectineus and iliacus from the femoral nerve depart from the nerve above the level of the inguinal ligament, and then below the inguinal ligament, the femoral nerve rapidly splits into its multiple components, including innervation for the sartorius, the vastus, and sensory innervation to the medial thigh and along the saphenous pathway, and also with some additional sensory along the sartorius. An approach to the more proximal femoral nerve above the level of the inguinal ligament is also reasonably straightforward, although the assistance of a general surgeon may be useful. The approach goes through the abdominal musculature to identify the femoral nerve, where it is passing from its point of emergence between the psoas and the iliacus muscles before it descends to traverse the level of the inguinal ligament. Now, one nerve component of the lumbosacral plexus that many neurosurgeons think of all the time is the lateral femoral cutaneous nerve, because of the risk to injury to the nerve from the iliac crest bone graft site, wherein failure to mobilize the lateral femoral cutaneous nerve from the medial aspect of the iliac crest can lead to an injury when the bone graft is taken. Now, fortunately, this doesn't have any significant motor consequence. However, it can cause a horrible pain syndrome, much worse than the original cervical spine problem for which the graft is being taken. And this is one major reason why the trend has been away from autologous iliac crest graft towards any number of different either cadaver bone implants or a wide variety of synthetic material implants with bone growth accomplished without the iliac crest graft. In the event that the nerve is injured, it may be necessary to mobilize the nerve from an area of entrapment, or to try to free a distal neuroma so that it is not adherent to the surrounding bony planes or surrounding tissues, so that it does not get constant or repeated traction on the neuroma with any movement or activation of the iliacus or psoas muscles. Another pain problem that neurosurgeons are sometimes called on to treat are symptoms of a more distal entrapment of the lateral femoral cutaneous nerve, often called neuralgia paresthetica, which can generally be treated by a neuroplasty of the lateral femoral cutaneous nerve as it descends between the tensor fasciae lata muscle and the vastus. But in some cases, it will be necessary to resect the lateral femoral cutaneous nerve and then to attempt to seal the terminus or place a neuroma preventing implant, some of which are now commercially available, and then to allow the proximal end to transpose into the abdominal space so it will not be pulled against the inguinal ligament and will not be as commonly aggravated by movement as will occur in its natural position. Now, although, as mentioned above, there are many very small targeted approaches that can be used to reach particular locations of entrapment of the sciatic nerve, and I also have advocated using a small approach into the area of the piriformis muscle and then mobilizing tissues internally to track the sciatic nerve for more distal nerve releases, and similarly for the posterior femorocutaneous nerve. Nonetheless, these nerve elements may be subject to major complex trauma, such as an injury that crushes the pelvis. I've also seen cases where a pelvic brim fracture was treated orthopedically with a plate, but the plate ended up impinging or crushing major nerve elements. This can also occur in hip replacement surgery that goes off track. And there are many other causes, penetrating injuries, gunshot wounds, where an extensile exposure is helpful. So the image on the right gives the general anatomy, sciatic and posterior femorocutaneous nerves, the superior gluteal nerve emerging above the piriformis, which innervates the gluteus medius, which can give pain up to the iliac crest, which mimics an L4-5 syndrome, and can cause a gait disturbance because of the role of the gluteus medius in stabilizing the pelvis during each step. Also, emerging below the piriformis, the inferior gluteal nerve to the gluteus maximus, as well as the nerve to the obturating turnus and the pudendal nerve. The general extensile approach for the sciatic nerve is detailed in the left panel illustration, showing a large curving incision which provides inspection access from the sciatic notch to a point in the mid-thigh so that an extensive exploration and repair as needed can be carried out. So this illustration focuses on the sciatic bifurcation, which usually occurs somewhere just above 2/3 of the distance between the gluteal crease and the popliteal crease, and at which point the peroneal nerve heads laterally along the medial edge of the biceps femoris tendon. This is important to keep in mind because not all common peroneal nerve entrapments are at the fibular head. There can be an entrapment at the point where the nerve actually crosses over the posterior aspect of the biceps femoris tendon, and palpation across this can be helpful to understand more proximal peroneal nerve entrapments. Another important sports injury that does happen with some frequency is a tear-off of the biceps tendon from the head of the fibula, sometimes with an associated fracture of the fibular head. Now, orthopedists are well equipped to repair this. Generally, they'll put some screws into the fibula, put stitches into the distal biceps tendon, and then pull the tendon down to the screws that are used to repair and attach to the fibular head. The problem with all of this is that very often the peroneal nerve is adherent to the biceps tendon and may also itself have been significantly injured or even severed in the course of the complex biceps tendon and fibular head fracture. Therefore, neurosurgeons are sometimes called on to identify and mobilize the peroneal nerve from the swollen, inflamed mass of damaged tissue often present when athletes come in acutely with these injuries. This is well worth doing because this is a substantially motor nerve that has a relatively short distance to travel from the fibular head to where it starts entering its target muscle, so that even where the nerve is severed, a nice repair there has a very good likelihood of restoring dorsiflexion. Also, it is important to remember that the process of causing major tendons and bones to repair themselves generates a lot of fibrosis. And so it's really helpful to isolate the mobilized peroneal nerve or repaired peroneal nerve from the biceps distal tendon repair and the any fibular head repair. And this is often best done with adhesiolytic materials such as Seprafilm or even the placement of Duragen or other resorbable materials that help prevent adhesions from extending into and interfering with nerve regrowth and nerve recovery. For access to the distal peroneal nerve, this incision commencing in the midline of the popliteal fossa and then crossing to a position anterior to the fibular head is advocated. And this is different from the approach used for the distal peroneal nerve entrapment, where you want to remain posterior to the fibular head as the skin incision descends. Now, in any sort of complex neuroplasty or repair affecting the peroneal nerve at the knee, it's important to consider the anatomy. For most routine entrapments at the fibular head, you can think of this really as a single peroneal nerve because most of the entrapment takes place before there's significant bifurcation or trifurcation of the nerve. However, sometimes the problem extends a bit more distally. The deep peroneal nerve dives fairly sharply inwards under the fibular head along the surface of the fibular neck and reaches deep portions of the tibialis anterior, while the superficial peroneal nerve proceeds distally in a more superficial location. The articular branch should be preserved when at all possible. Also keep in mind that although the most common point of entrapment of the peroneal nerve is at the fibular head and neck, in some cases it's the course of the common peroneal nerve and proximal superficial peroneal nerve at the margin of the peroneus longus muscle where the entrapment point occurs, and therefore you may need to divide the margin of the peroneus longus to assure a good decompression. Also, in the event of trauma, this is the approach to take to where you need to do a repair. This is the approach to take to get better distal exposure. Whereas for the deep branch of the peroneal nerve, you may need to section through the extensor digitorum muscle and subsequently repair it in order to get optimal access for repair of the deep branch of the peroneal nerve. In some situations, you also could be called on to do surgical repair for the tibial nerve. So more superiorly in the calf, you can do an approach between the medial and lateral heads of the gastrocnemius muscle, and that should give you good access to the nerve after traversing through or over the soleus muscle. Now, for more distal access along the tibial nerve, it's helpful to keep in mind that firstly, it runs with the posterior tibial artery, and this will help you find your way to the distal tibial nerve. Also, keep in mind that the flexor digitorum longus extends medial to the descending tibial nerve and maintains this relationship on through the tendon of the flexor digitorum longus, and as both the distal tendon of the flexor digitorum longus and the distal portions of the tibial nerve traverse the tarsal tunnel in this relationship as well. And then laterally, you would have to be able to lift and move gastrocnemius as well as soleus components or Achilles tendon components in order to get the best lateral exposure to the tibial nerve. And then for further approaches for ankle onward, we refer you into chapter 276.